Just 1 second. Okay, so everyone has I did the screens right. Everyone has the right view.
Yes.
Yes. Okay, great. And if it ever gets hard to hear me, just let me know. I can move around my microphone here. But today I was asked to talk a little bit about the assessment process that happens when someone is interested in pursuing bariatric surgery. Initially, when I was thinking about doing this, I was going to talk a bit about the assessment and treatment portion, but I changed the title because there's a lot to cover, and I wanted to be mindful of leaving plenty of space for questions and discussion instead of kind of lecturing and cramming it all in. And so today we'll focus on the assessment piece. And I welcome questions throughout. People are welcome to just kind of chime in. I have some of the, I can see some faces the way that I have my screen set up, but maybe the chat I won't notice as easily. So people can feel free to just interrupt and ask questions throughout, but we should have time towards the end as well. All righty. So today, an overview of what I hope that we'll be able to get through is starting with an introduction about bariatric surgery, talking about what is bariatric surgery, why do some folks have it, why does that seem helpful for them, and in talking about the bariatric surgery process leading up to the procedure, I'll talk a bit about what patients who pursue surgery go through and how there are many stops along that process, and one stop is meeting with a psychologist or a different kind of mental health provider for that workup, the medical workup process. So within the psychological evaluation, I'll describe a bit about what I look at and some details of what that appointment consists of, at least when we do it here in this department at WVU. And then we'll spend some time talking about, after that evaluation happens, what's the outcome, what happens next, and how does that get decided. So to start with talking about what is bariatric surgery. So that's just the name for a category of weight loss surgeries. And there are many different types of procedures that are for weight loss and that are considered bariatric surgeries. But when we talk about in general, what does bariatric surgery do? The surgery can change the structure and the function of someone's digestive system with the goal and the objective being to make weight loss happen within the body. So sometimes a procedure works by limiting the quantity and the volume that someone can eat. Some of the procedures work on reducing the body's ability to absorb nutrients, and some of the procedures do a combination of both of those things to make weight loss happen. So though there are several different types of surgeries, I'm going to describe two of the most common at this point in time. So one is called sleeve gastrectomy. It's also called the sleeve. So if you've ever heard people conversationally say, oh, I know this person who got the sleeve, or on this show they talked about the sleeve, that's what this is referring to. And I always want to clarify up front, because I've heard this from a number of people, that this procedure is not actually putting a sleeve onto something. There's no foreign object that is entered into the body, which is not the case for all bariatric surgeries. For example, the lap band is like a foreign object that gets put into the body to affect the stomach size, but that's not what this is here. So the picture on the left hand shows what the esophagus, stomach, and small intestine would look like before someone would have the procedure. After this procedure, you can see what it would look like. So the gastric sleeve section on the right-hand picture is that very reduced portion that kind of looks like a banana. That's the stomach that is left over. And then the piece that says surgically removed stomach section, that is taken out of the body. So about, I mean, it depends on different estimates you read, but well over half, well over 60% of the stomach is cut out and taken out of the body, and what is left resembles a banana shape or a sleeve, and that's why it's called the sleeve, but there's no like sleeve that they put over it. The sleeve is different than bypass, and you may have heard about people saying bypass surgery. So this is also a type of bariatric surgery. The picture on the left shows what a stomach and small intestine would look like before having gastric bypass surgery. And this one's a little more technically complicated, so I wanted to show this picture because it can be confusing to understand what is changed with this surgery. So with bypass, nothing is physically taken out like we saw with sleeve. There is the gastric pouch, which is now the new stomach, very small. But the bypass portion of the stomach stays inside of the body, and it stays connected to the top portion of the small intestine and links back up with the other portion of the small intestine. So food goes from the gastric pouch to that like tan portion, but different digestive juices still go to the other part of the stomach and through the duodenum, which is the top part of the small intestine. So a little confusing, but nothing gets taken out, and it's still a really small stomach in this. So that's some examples of what are bariatric surgeries, what do they do, how does it change the internal body. Just a brief point about how prevalent bariatric surgery over time has been. So these are estimates of the number of bariatric surgeries in the country from 2011 to 2020. The top two rows say sleeve and RYGB, which stands for gastric bypass. And you can see there's a bunch of other types and stuff, and we won't focus on those for today. But in 2020, about 61% of all bariatric surgeries in the country were gastric sleeve. Of note, at WVU bariatric program, which is what I work for, we do closer to about 90% sleeve. So sleeve is definitely the majority procedure here, even more so than what these numbers are reflecting. So just a little bit about why would someone have bariatric surgery if this is a pretty unfamiliar topic to you. So obesity is a disease, and I point that out to dispel misconceptions about excess weight, overweight, or obesity being related only to lifestyle factors, therefore thinking it's only about things people can control. Though people say this, it is not true. It's not just food in, like calories in, calories out. It's so much more complicated than that, and involves a lot of different aspects of the body and hormones, and all of the causes and maintaining factors of obesity are not even fully understood by medical doctors at this point. So I say that up front to dispel beliefs about like someone shouldn't need surgery because they could just eat less. Like that is absolutely not true. And that's a very harming mindset when if people have that towards patients. So beyond the fact that it is a complicated disease process, if someone has excess weight and their body mass index puts them at a range of severe obesity, they are much more likely to have other diseases that come before, during, or after obesity, such as diabetes, heart disease, cancers. There's a high overlap in the prevalence between obesity and many different kinds of cancers. So it puts you at higher risk for a lot of stuff that someone might not have yet, they might develop down the line. And all of this really does impact quality of life. A lot of patients that I meet with for the pre-surgical evaluations may already be on medical disability for weight-related conditions or comorbidities. And it can shorten the lifespan for folks as well. So these are all reasons why someone might consider having surgery as a type of treatment for obesity. So if someone is presenting for bariatric surgery, it is not just that a patient meets with a surgeon. Maybe at some clinics, it's a bit boiled down and a little more simple like that. But in general, it's recommended that bariatric surgery takes a team approach where a patient would meet with a dietitian, their bariatric surgeon, of course, with nurses, maybe with a physical therapist, an exercise physiologist, with a mental health professional for the evaluation. And having a psychological evaluation is essentially a requirement. Generally speaking, insurances are not going to clear and pay for this procedure without having a lot of clearances, including the lung doctors say it's safe to do the surgery, a heart doctor say it's safe to do the surgery. And so psychological clearance is one of those things that's a piece of the puzzle, and it's not optional, necessarily speaking. Any questions from folks before we start to dive into the actual pre-surgical psych evaluation? Okay, sounds like it's all crystal clear so far. Okay. So, as I mentioned, especially at least in this program, every single patient who is pursuing bariatric surgery has to come talk to a bariatric psychologist or some of the trainees that we have working in our clinic. So we have Emily here on the call, not that I'm going to ask her to unmute or say anything, but she is a new pre-doctoral psychology intern at WVU, and she's having a 6-month rotation in bariatrics. And so she's new to doing this type of appointment, though she has a lot of training in psychology. And so these are the things that a mental health professional does during this appointment and what the point of this type of appointment is. So one of the main points of doing this is to be looking at someone's risk factors from a psychological perspective and seeing if it's to an extent worth the risk and benefit ratio. For example, hypothetically, if getting bariatric surgery was expected to make someone's overall life worse or be very dangerous for them from a psychological perspective, we would not want to just say, good luck, hope it goes well, and like wish them on their journey when we think we know what that journey looks like. So we want to understand risks, benefits, and talk with them about that, because we meet with thousands of patients, we have a lot of research, and we see trends and what to expect. Part of this is what maybe people think of more readily about having a diagnostic assessment. So someone might present for the appointment and have never met with a mental health provider before. And they may have symptoms or conditions like anxiety, depression, PTSD, panic disorder, but they may not know it, or they may have never been told that that is a diagnosis that they have or that they meet criteria for. So that's not the only point of the appointment, but it is something that occurs during the appointment. Psychoeducation is referring to a teaching process. So this happens in all kinds of appointments and has different names, but hopefully during medical appointments, the patient is learning things to help them take ownership over their own health care. And this appointment is no different, that there's time where we're teaching different skills or topics, and sometimes it's education about their own diagnosis. I often get people saying, well, I can't be depressed because I don't do X, Y, Z, or depression means I can't get out of bed and I go to work every day. So that would be an example of psychoeducation, of saying, actually, I hear what you're saying. Also, you present with these things, which is in line with depression in these ways. And so it's just teaching. Something that is important is, though it might sound contradictory to, not contradictory, but it's hard to do all these things and also keep rapport. But we do care about keeping rapport with patients because we want them to be willing and open to come back to a mental health service if they need it related to the surgical process. So we don't want the appointment to be just focused on information at the expense of their experience, no matter what, but especially because we would want them to consider us and keep us in mind for their needs, and not say, she was horrible to talk to, I'm never going back there no matter what happens. We'll get more into this towards the end, but something that happens during the appointment is developing a treatment plan with recommendations. And this appointment is not done in isolation. Being a bariatric psychologist means that I'm a part of the bariatric team. And so we share information with each other to make the care as good as possible. So we're coordinating with the nurses, the dietitians, and the surgeons to make sure everyone's on the same page about what that treatment plan looks like. And overall, the whole point is we do all this to try to give the patient the best outcome. That's what all of this is for. It's not so we can say that we were right or that we knew what we were doing. It's because if someone's going to go through this process, they have expectations of what they get back from it, and we want to help them with that. So when it comes to the actual psychological assessment, you may think, okay, well, that's the point of it, but what do you actually look at and what are you assessing? So the American Society for Metabolic and Bariatric Surgery is the largest entity that oversees bariatric surgery stuff in the country. And they put out guidelines and recommendations and best practices. So not that everyone goes by that, but it's advised that you do. So we will talk about what they say should be assessed during the psychological evaluation. Part of it is the patient's knowledge about bariatric surgery. And depending on the center that this is happening, the team might delegate this task to other team members. So here at WVU, knowledge about surgery is not something that the psychologist focuses on as much because other team members present that, test and assess that. But when I worked at UIC's bariatric program, I would spend about 30 minutes of the evaluation checking in with them about what's the name of your procedure? What does that mean? How is your stomach shape going to change internally? How does the procedure work? What are things that you can and cannot do after surgery? So we're trying to just make sure they understand the treatment that they're pursuing. Also understanding the patient's history with their weight, with dieting. We have great dietitians on our team at WVU, and there's 4 of them. And so every single patient has an individual dietary intake when they start the program. So the bulk of that information is at that appointment. But during the psychological assessment, we keep an eye out for these things to see if there are problematic or concerning things in the history that might trip them up during surgery. We do want to understand someone's current physical activity level, and at least at WVU, a standard that we have is wanting patients to implement some kind of intentional and structured physical activity program. That does not mean it has to be whatever someone perceives as exercise. That could be walking 15 minutes a day, 4 times a week. For patients with mobility limitations or pain, it's certain stretches or physical therapy exercises. So it's not as much about what do they do, it's about, is it a part of a routine and a lifestyle, at least the approach we take here. Of course, it's important to understand someone's eating habits and if they potentially have an eating disorder. And an eating disorder is different than disordered eating. For example, bulimia is an eating disorder and emotional eating is not an eating disorder. But if someone has daily emotional eating when they present for this appointment, that's still a problem, even though it's not an eating disorder. We want to identify that and help give support for that, because they're not going to do as well if emotional eating continues to happen after surgery. As was alluded to on the last slide about the diagnostic assessment piece, of course, we want to understand current and past psychopathology, meaning does someone have a mental health disorder? Even if they don't meet full criteria for a disorder, are there distressing symptoms of panic, anxiety, depression, OCD? And understanding if someone has treatment support already, like they have a psychiatrist, they have a counselor, they're in couples counseling, or if that's ever happened in the past. We talk with everyone about drinking, smoking, and illicit drug use the whole time throughout their life. We want to identify if someone has had substance abuse or substance use disorders before surgery. It is important to get a sense of medical adherence for patients. So common things that can come up is often a majority of patients in the program before surgery are on medications. I think that I've only come across less than 5 patients here in 2 years that had 1 or 0 medications on their medication list. So that's a good example to understand how well they follow directions with taking medication. How well do they understand what the directions are for their medication? How do they remember to take medicine? When do they take medicine? So assessing medical adherence, like in addition to medicine, it can be attendance to a medical appointments. And if someone has to wear a sleep apnea machine, like, do they do that? How often do they do that? We want to understand social support in general and for surgery. Sometimes the patient is on board with surgery and other people are not. And if people in their home actively don't want them to have surgery or are a bit more ambivalent, that's going to affect how the patient does. It's hard to change your lifestyle in a lot of ways if people are not supporting you. And then especially if they're actively working against you and bringing home things that you're trying to stop buying or stop having. And sometimes sabotage does occur. So we want to understand who and how are they getting support for this huge process. It's very important, in addition to understanding someone's current mood, to really get a sense of stressors at the time of the evaluation and recent life events. There have been numerous times where I've asked someone, how would you describe what your mood has been like in the past week? And I run through and screen for depression, screen for anxiety, and people have said, no, 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 no. And then I circle back to, you know, any current stressors going on right now, or what would you say is most stressful, or any big changes recently? And sometimes people are like, oh yeah, XYZ person died, or oh yeah, I found out that blah, blah, blah has terminal cancer. And I'm like, where was this for the past 10 minutes? Like, what if that's a stressor, or that's a big change that we need to know about? And sometimes, depending on how you ask the question, it didn't come up about mood. It didn't come up about depressive symptoms, but I don't think that they're always admitting it on purpose. I mean, I think that sometimes it's just like, oh, I didn't think that was relevant, or I didn't think you'd need to know that. And that's why we have to ask directly. So to get a little bit more of a specific sense of what would it look like if someone was attending this kind of appointment, patients in our clinic are asked to arrive to their appointment 15 minutes before the appointment time starts. During that time before the appointment, there are online questionnaires that we make sure that everyone fills out, and that's a good time that people can do it. And the appointment time typically lasts 1 hour, though that is less for some people and longer for other people. Some of this has changed since COVID. Before COVID, every single person was coming in person for these appointments, which it's hard for me to imagine because I did not work here then, but our clinic serves people in nearly every county of the state, and then even people in Pennsylvania, Maryland, Virginia. So to think about what that drive time is like, to drive 4 hours, to sit in the waiting room, to fill out a questionnaire for 15 minutes, and then have to talk to me for an hour, like that's before the appointment starts, that's exhausting. So I do think that a silver lining is that we got up and running with telehealth services for the psychological evaluations. So people still have the option most of the time to decide if they want to do this appointment through video telehealth or come in person. In my experience, most people elect to do the evaluation through telehealth. And if they need follow-up or therapy services, sometimes they choose to do that in person. But most of the evaluations are still done through MyChart, which is through Epic, our electronic medical record system. So then it's a little different if it's through MyChart, because they're still expected to arrive 15 minutes early, but then they just sit there waiting in a virtual waiting room. They do still ideally do the questionnaire beforehand, and the appointment time should not change too much because it's through telehealth. During the appointment, all of those things that we've already talked about are assessed, and then before that appointment is over, recommendations, a treatment plan, and a verdict is discussed with the patient so they understand next steps and what's happening. And we'll get into it next, but a follow-up appointment or several might be required as an outcome from the appointment. Any questions, thoughts, curiosities so far?
Feel free to chat in too if you want to. Keep an eye on that.
Thank you. So we'll spend the last bit of time talking about outcomes, and then I do intend to leave time where I take away my slides and we can look at each other and talk about things if of interest. So I thought it'd be helpful to show some examples of recommendations that can come from the evaluation. Because like I mentioned, there's many objectives of the evaluation, and something that happens for everyone is that they get recommendations. So some examples of things that they might be recommended to do. If relevant, of course, these are tailored per person to what is helpful to them. But sometimes we recommend that patients should attend a treatment group that our clinic has. It is virtual. It's called a binge and emotional eating group, and it's 3 different sessions, 1 hour each. So it's pretty short-term treatment, relatively speaking, but we do that on purpose so we can help move people through the program. Often a recommendation that comes up is needing to improve depression, anxiety, or stress management before surgery. And that can look different per person of how that happens. But if people are willing to take medication to help with those things, that is often discussed because time is of the essence with the bariatric program. It takes long enough as it is. Before COVID, I guess it could take people as short as 3 months from the time they start to when their surgery date's scheduled, but more often it's 6 months, 8 months, a year or more with a lot of COVID delays. And so if we say, go to individual therapy for a year and then come back, that might be the absolute best recommendation. But when you weigh pros and cons of what's realistic and what's going to benefit someone, what happens in all that time that passes? What happens to all their health conditions as they are delayed from surgery for that long? So getting care with a therapist or medicine through a primary care doctor or a psychiatrist is often talked about. Patients need to not be using any type of nicotine before surgery. And so if someone's having a difficult time with that, a recommendation might be, well, to quit, but we don't just say quit, we talk about how and why. So there's treatment options for that. We might have varying levels of familiarity with SMART goals here, but SMART goal setting is a helpful tool in the recommendations to pick a topic that's helpful for them to change, but to give them some of that assistance about what specifically to change, when to change it by, how to change it, and make all of that spelled out more specifically. Food insecurity is a common problem, especially in the state of West Virginia for patients that I meet with. And if they don't already have access to supplemental food services, food stamps, or know where food banks are, those are things we can talk about and get them connected to, because having access consistently to food is important to establish before having a health and weight loss surgery. And we have a Facebook group for people in the bariatric program that is a good source of social support if they're really not getting that from other sources. And even if they are, we can supplement that. So I'm sure that folks might get curious about what happens if they don't get cleared right away, or why may that happen? What would it take for someone to have a bit of a delay or to take more time before they're able to move forward with surgery? So here are some examples of things that are either straight up contraindications, meaning this cannot happen and be actively pursuing surgery, or it's serious enough that it's going to objectively delay surgery, which is different than saying, work on these things, come back in a month and we'll talk about it. A delay would be, you're going to be on hold for 3 or 6 months because this thing already happened and it's not safe, so we need to give more time. So, and a lot of programs spell these things out at the very beginning, so someone doesn't waste 4 months doing appointments and then get told this afterwards. So it's pretty standard within bariatric programs that if someone has had a suicide attempt within the past 12 months, that they are not eligible to start the program. So ideally more time would pass and more support would be given before they are even eligible to start having appointments. Sometimes people have passive suicidal thoughts or more mild, fleeting, and frequent suicidal thoughts. And if that has happened, that doesn't mean that they can't be in the program. But if it's severe and frequent and intense, that may justify a hold. And it's odd to think about it this way, but stay with me here. If someone is having the future-oriented process of planning a surgery to improve their health, to extend longevity, it is important that when they're preparing for that, they are future-oriented and that they are not thinking about ending their life in the near future, because those things don't go together. Of course, it's not that simple within mental health, but if someone is really struggling with the day-to-day and the here and now, that is not compatible with long-term planning for a life-altering surgery. So that's why that's important. If someone is having active substance abuse or a substance use disorder, that is of major concern, and we would need to more specifically spell out a plan before someone move forward with pursuing surgery. It definitely comes up that sometimes when people are first joining the program or meeting with me for the evaluation, that they might be experiencing homelessness or having domestic violence and a lot of instability at home of things changing. Maybe they're considering divorce, on the cusp of divorce. It might change their income status. It might change their housing availability. It might change their social support. So depending on what the nature of the circumstances, that has different implications. I think our program is very reasonable and approachable about these things. We don't want to discriminate against people because they're having a hard time and make things worse. But again, that risk and benefit ratio, if rushing them through and giving them surgery makes their life worse and is dangerous, we are not ethically allowed to facilitate that if we suspect those things. Of course, if someone has an active and severe eating disorder like bulimia or binge eating disorder, we would want to slow things down and be giving proper treatment for those things, because again, it can become very dangerous after surgery. Sometimes people think about surgery as you join the program, you do things, you have surgery, and that's it. But really, it's not the end. It's the beginning, because then there's years and years and decades of life for a lot of people after surgery. And what happens then? Does someone get depressed again? Do they start drinking again? Do they have bulimia come back? And so like we think about those things too. This isn't just the short term. This is about lifespan and quality of life. So as it may make sense now, sometimes follow-up appointments, whether it's checking in, whether it's helping with goal setting, whether it's making it more of a developed treatment plan, those things often happen with psychology of not just having the eval and being done. There's things that need to be implemented sometimes to help people be safe and successful. And though this is not everyone on the team, it's a long flyer with lots of faces. Just wanted to show you your friendly local bariatric team. So as of right now, we have 3 bariatric surgeons that are on the top row. Also on the top row, we have 2 of our medical doctors who are part of the medical weight management program, which is non-surgical. We have 2 bariatric psychologists, including me, and then physician assistants, nurses, dietitians, folks that help with the scheduling, insurance processing, and all of that. So with that, I will for now stop sharing and open it up for a bit of time. And if needed, I can bring my slides back up.
Thank you so much, Laura. You did a wonderful job. You just have a very calm voice too, but you did really hit everything important that goes into this and how important it is for all the different types of medical professionals to be involved. I think that's essential in a lot of treatments, or it should be. Does anybody have any comments or questions? Dr. Sagar said, thank you. Great job. That was great. Quiet group today. It's okay.
Yeah, usually everyone's more chatty. I feel like if Colleen was here, she would mix it up and make people say things to me.
Say things to me. I will say, I think it would be challenging to see if somebody is like when you were talking about having, negative suicidal thoughts or for their future. I think that would be hard because I think is it sometimes correlated with how they are feeling about their body, and themselves. I mean, I think at least for me, I think sometimes you do feel really down about how you look and that, influences how you're feeling at the time.
Yeah, and it can be really challenging. And though I tried to present this in a way that feels organized and like there's bins and boxes and check marks, like it's messier in practice. And ideally we want to standardize things and we want it to be consistent, but it's not to oversimplify how these decisions are made. And Emily gets to get a deep dive into that from now until December and really get hands-on with how to talk to patients about these things and how to make these decisions. But yeah, to your point, Elizabeth, more specifically, it's challenging. I think that's where a really thorough assessment comes in, because the nature of someone's depression matters for this. The nature of someone's passive suicidal thoughts matters. And then also that's why history matters. Not that we are going to use someone's history against them, but if someone has a history of 5 suicide attempts, and it's all the same method and it was for similar reasons or similar triggers, then we want to know those things because it can speak to how serious their suicidality may be in the moment or how eminent that might be for them. So it is tricky because we don't want to be making things worse for people by saying we're going to withhold this treatment that's going to help with your chronic pain and help with your, I don't know if I would say help with body image because that gets very complicated. Body image is separate than someone's weight. And sometimes if someone has a very complicated relationship with body image, weight loss doesn't make that go away. It might just complicate the nature of the body image concerns. So yeah, it's tricky, but it's been very humbling for me to get used to how things are done at WVU's clinic, because the clinic is very responsive and sensitive to the residents of the state and who is the state serving and how do we serve them. And that looks different in different places. So when I did this in Chicago, there are many hospitals and clinics and surgeons who do surgery. Doesn't mean it's accessible to everyone necessarily, but I worked at a state university hospital similar to this. So it served the state, it took Medicaid, Medicare, and surgery was just a bit more accessible in Chicago because of how many places you could go to get it. But here, there's less places. And so if we set a bar really high and say you cannot be depressed, you can't have chronic pain that interferes with exercise or cooking, you have to have this much money, you can't be on food stamps. Like if we set this bar, how much treatment are we withholding from people? That doesn't help them by saying you can't get this. But then it's not for us to be mean and withhold, it's also to make it safe. So our job often becomes that optimization of maybe it's not great. Okay, we're here. can we at least move it here? And then you have surgery, like we're just doing, we need everyone to be safe, but not everyone's going to be an amazing candidate, but that's not my job. The bar isn't, you have to be amazing to be allowed to have it. They need to be safe. We need to think that they're still going to be alive in 5 years. That is mandatory, but the success and the outcomes, not everyone needs to lose 60% of their excess body weight. If you lose 25% of your excess body weight, there's benefits. So, I mean, it's just about having expectations, being open with those expectations, and being fair. And fairness gets complicated sometimes.
Thank you. Very well explained. Appreciate that. Anything else before we have our closing remarks?
I know you've sort of probably alluded to this a little bit, but I wanted a little bit more of sort of the practical sort of side of it. Certainly a lot of the medications that we prescribe in psychiatry have weight gain as a side effect. Especially, I know it's a huge issue in the pediatric population. And I wonder how much or how often, like especially medicines for bipolar disorder, I guess, play a massive role in weight gain and they contribute to obesity, which also carries with it a very high suicide rate in terms of safety. And if you had any additional clinical insight into that in this, I don't know how common, I guess it is, but as I said, I certainly, and then it comes back to what I think Elizabeth was saying, that often the treatment for the mood problem causes lots of other emotional things, and I wonder how often you actually see that.
Yeah, I appreciate those thoughts and curiosities. It's very common that when I see patients for the evaluation that they're on psychotropics, first of all, like that is more than a coin flip chance that someone's on a psychotropic when they present for the evaluation. We see a lot of folks on mood stabilizers or antipsychotics as well. So that's not a rare thing of like, oh my goodness, we don't see this. Like we see it weekly, monthly, all of the time. So far in my practice, because there's so much to do and learn, I have focused less on what specific factors caused weight gain over time, because we do have a team that focuses on some of that. And of course, it's relevant to the extent that it could lead to weight regain. So specifically when it comes to mood stabilizers or psychotropics, I don't spend as much time focusing on that as one of the originating causes, because there can be a lot of other causes, and then it's splitting hairs between what caused what and how much, and we don't even understand obesity. So I'm like, who am I, especially not a medical doctor, medically trained, to parse out how much is contributed because of, Depakote or different things. But I will say I hear anecdotally often from patients that I hear more often that they feel like their birth controls, whatever type, that certain type of birth control has impacted their weight. And then often for a lot of patients, it can be PCOS and their birth control and this and psychotropics, and like they feel anecdotally that the timing of when their weight status changed a lot aligns with those things. But what I can say is that's why the team approach is helpful. I refer to psychiatry here often, and I try to be mindful of how often I refer, because we have a long wait list for adult patients and probably all patients, but we have patients who need that specialty service. It's not sufficient sometimes for people to just have their primary care provider or their PA dealing with their psychotropics because of the weight gaining and weight related aspects. So sometimes I do need to outsource, because I know that I'm not qualified to do that. But a lot of people feel that their medications have contributed to their weight status at the time, and then after surgery, providers need to be mindful of how to optimize their medication list that doesn't go against their goal of just have had surgery.
Excellent. Thank you so much. Yeah, we could spend a whole other session on that. I could be like a candidate if you want me. If you need a case, I will be your case. All right. Does anybody else have any comments or questions? Okay. Well, I really appreciate your time. Great job, Flora. And thank
I
you.
appreciate that. I appreciate everyone's attention. And as they mentioned in the beginning, for it can't be trainees, unfortunately, but for peers, so people, they don't have to be psychologists, but peers, if you're willing to fill out that form, it's just a couple questions. My department requires I get feedback about times that I give talks, and I don't always give talks, so that would be helpful to have if you're willing to do that.
Absolutely. I'll send that out with a recap later on this afternoon. So our next session will be July 20th, and Amanda Newhouse will be discussing cell phone and screen time addiction. So again, thank you so much, and I hope you guys have a great rest of your week. Bye-bye.
Thanks, everyone.